The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, TMD warriors. We are gathered here for the next episode of TMD Demystified. I am Tony Urbanic. Today's topic and title is Causes of TMD Inflammation. Causes of TMD inflammation. What are the causes of TMD inflammation? We're going to dissect that. We're going to talk about it extensively. But before we get into that, I'll just basically announce that I had covered this before. Actually, I looked at previous episodes. I covered this same topic 2 years ago in August of 2021. Today, I'm going to take a little more detailed look at it. I think it's time to talk about it again because I had a conversation with a young dentist recently minted from a national United States dental school, who in the middle of the discussion regarding temporomandibular joint problems, it became obvious to me that this doctor did not have basic understanding of inflammation, which totally blew me away, surprised me. I won't go into the details, but in our conversation, it became obvious that when it came to the word inflammation, she could not connect it to the basic pathology, the parts of inflammation, the basic things that I would think that we all should have learned in the basic sciences in dental school. I can't explain it, don't need to, but it reminded me that I don't think she's alone. I have recommended at many different times in my discussions with potential network providers who provide our service for temporomandibular joint disease, the device and protocol, that as I lecture, as I talk, that there are big holes in the understanding of inflammation because, and it's important because inflammation is everything, means everything, is associated with everything, including all the symptoms, especially the symptoms of temporomandibular joint disorder, singular. It's not disorders, it's one disorder. The disorder is inflammation within the temporomandibular joint. That is temporomandibular joint disorder. And then everything else stems from that, including all the symptoms and all of the biochemical things that occur with inflammation that create those symptoms. So I just kind of bring that to the head here to talk about why it's important to talk about inflammation, but we're not going to dive deeply into inflammation itself. I'm not sure that I want to cover all the science that is presently known and the science that is unknown and being studied about inflammation. It doesn't get deep. It appears on the surface very complicated. And there are very, very good scientists and studies working on inflammation. And I have said before, and I will stick by it, that I believe that most of our chronic diseases will be solved one by one when we fully understand inflammation and all the ramifications of inflammation on all the systems of the body. Because inflammation in any one part of the body has significant effect on all the systems, including the immune system, the nervous system, the endocrine system, the cardiovascular system. And so it basic is, the study of inflammation spills over into just about every kind of pathology and every kind of medical dental issue that we as doctors have to address. All right. So with that as a preamble, let's just talk about the title of this presentation, talk, lecture, episode, is the causes of inflammation of the temporomandibular joint, because inflammation just doesn't come out of nowhere on the joint. And the inflammation in the joint, hopefully you will have already had this knowledge by listening to other episodes or just your basic understanding, is that once a joint becomes inflamed, any joint, temporomandibular joint, the TMJ is no different than the knee or the elbow. It's a joint. It can become inflamed. And once that inflammation takes hold, it has all kinds of effects locally and systemically through the systems of the body, the immune system, the endocrine system, the nervous system, which again, it's not what we're going to talk about. Basically, we want to just talk about those causes that cause inflammation within that temporomandibular joint. So inflammation is the linchpin. It is the central item that creates all the symptoms, and the three causes, and there are only three to my knowledge, causes of inflammation within the temporomandibular joint are bruxism, acute trauma, and functional malocclusions. Now, there's a fourth item that was brought to my attention that I'm not sure it deserves a special section regarding the causes of inflammation, but that is idiopathic juvenile arthritis, IJA, idiopathic juvenile arthritis. Idiopathic meaning we don't know what causes it. It is inflammation, and that inflammation does exactly, in juveniles, does exactly what the inflammation in the temporomandibular joint does when it's caused by bruxism, acute trauma, and functional malocclusion. What we don't know, and what is under study, is how juvenile inflammation, idiopathic juvenile inflammation, is created. I think that would present an opportunity to do actually probably a couple different episodes, which maybe in the distant future we'll consider doing. Well, let's just talk about these three, because it amazes me that the doctors that I talk to have a hard time getting their arms around the fact, number one, that there are only three causes of inflammation within the temporomandibular joint. And of course, if you can avoid the cause, then you won't get inflammation. And if you can't get inflammation, then you won't have TMD. Now, that is quite simple, huh? But the three causes, we'll just start out with bruxism. Let's talk about what bruxism is and what bruxism isn't. First of all, bruxism, by definition, and excuse me for getting very basic with this, because this episode is designed for people who do need the basic information. And if a listener knows all about this already, then you can turn on the off button. But bruxism is defined as both clenching and grinding. Clenching meaning just with force, holding your teeth together, and grinding, holding your jaw back and forth. But basically, they do the same thing. What's the basic thing they do? They overload the joint. Bruxism and clenching and grinding do the same thing as overloading a knee when you jog for 40 years. And you will sooner or later overload the knee, and the knee will become inflamed. Or you overload a hip, and the hip will become inflamed. Now, so bruxism is nothing more than an overloading of the temporomandibular joint, creating inflammation. The bruxism itself is poorly understood, actually almost not understood, as to what causes bruxism, or the mechanism of bruxism. We know that bruxism is intimately related to stress and anxiety. Stress or anxiety creates a plethora of activities within the central nervous system and the body through the autonomic system that I've mentioned before. But stress and anxiety is in everyone's life. I don't know of anyone on this planet who does not have significant times of stress and anxiety, which in some patients, not all patients, converts into clenching and grinding the teeth, bruxism. We do not understand the mechanism, the central nervous mechanism for bruxism, how anxiety and stress convert into clenching or grinding the teeth. We know generally where it operates from, and that is in the central nervous system in the brainstem. But I think that there probably is a very complicated mechanism. It probably has a lot to do with different factors, health factors within the patient, how well what their nutrition is, how well their sleep patterns are, probably genetics, probably the health of the endocrine system, the health of the immune system, which kind of tips some people into bruxing, and other people can have all kind of stress and they don't brux. So the bottom line is we do not understand bruxing from the standpoint of what is really going on there. And it is actually humorous to hear and to read things on the internet, or to hear doctors talk about what patients can do to keep themselves from bruxing. Obviously, if you're overstressed, if you have a lot of stress, yes, you can do things that decrease stress. Clean up your health, clean up your diet, clean up your rest, clean up your exercise. Those are very helpful things to do. And maybe that might have a significant effect on your level of anxiety, which can decrease bruxism. But there is no pill, there is no mechanism that we understand that we can intercede in stopping bruxism. So those that brux are always going to brux, greater or lesser, during times of their life. And when you brux long enough, the dentist will see all kind of damage, periodontal damage, dental damage, attrition, fractures. And of course, if you can fracture a tooth and wear down a tooth to 50% of the original size, you certainly can put enough loads on the temporomandibular joint to damage the internal structures of a joint, which are soft tissue structures, which then creates chronic inflammation, where the symptoms of chronic inflammation are in the joint: headache, earache, jaw pain, neck pain, tinnitus, subjective hearing loss, vertigo, upper back and shoulder pain, arm, hand, finger tingling, and numbness and locking, all created from bruxism, inflammation in the joint. That is the sequence. The second item is acute trauma. Now, acute trauma can be early in life. Once the damage is done from an acute trauma, the joint may not recover completely or at all. In my experience, the most common kinds of acute trauma to the temporomandibular joint, that is the most common type, and there are many, many types, are motor vehicle accidents. and the most common type of motor vehicle accident that causes acute trauma leading to chronic inflammation, acute trauma, acute damage, and chronic inflammation within the joint are whiplash injuries. And I have shared during other lectures a slide that I show where it exemplifies how a whiplash, where the neck is rapidly snapped back in a motor vehicle accident, will also snap open the mandible well beyond its limitations, which will then basically create acute trauma within the structures within the temporomandibular joint. Acute trauma, unhealing, leading to chronic inflammation. Now, there are many types, as many times as you could theorize many types of acute trauma to the face and the jaws. Bar fights, 4x4s falling off the back of a pickup truck, bicycle accidents, even going well back in early childhood, can damage unilaterally or bilaterally a temporomandibular joint, causing dislocation of the disc or acute trauma of the internal surfaces of both the meniscus and the glenoid fossa and the condylar head, leading to chronic inflammation. So acute trauma can be caused as an adult. It can happen as a child. Around here in Middle Tennessee, I find, and I was amazed to see the number of people. Saw one patient yesterday who had quite a fall from a horse. Horse accidents are very common around here, and people, fall off horses and hit their head, hit their face, hit their jaw, break an ankle, break a shoulder, break their back. So acute trauma can come from many different directions, but all leading to, when the trauma comes through the mandible, through the jaw, transfers into the temporomandibular joint, damage within the joint acutely, leading to chronic inflammation, leading to the symptoms of TMD. And then the third cause of inflammation within the temporomandibular joint is functional malocclusion. And I've spoken on this many times, but I'm bringing all three of these together, including the quote fourth, which I'll have some comments on, about idiopathic juvenile arthritis, beyond what I've already done. This functional malocclusion is the one that is least it's least understood by most. Everyone knows what the definition of a malocclusion is generally. The teeth don't fit together correctly. But then again, the definition, well, what is the line? Where is the line between, well, it kind of fits adequately, or it doesn't fit at all, or it's a pathological occlusion? So a functional malocclusion is in the eye of the beholder, I believe, in dentistry. As an oral and maxillofacial surgeon, I was convinced that a functional malocclusion is a huge class 3 mandible, or a significant class 2 mandible, or an open bite of a centimeter that needs orthognathic surgery. And that was my definition of a functional malocclusion for a large part of my career. If it was just a small deviation, then, that was just a little bite problem that the orthodontist could handle. But when I really got into the research and I really got into examining temporomandibular joint problems, I found by watching, listening, and examining the patients that it doesn't take much difference between centric occlusion and centric relation to create a functional malocclusion, overloading a joint, the temporomandibular joints, adequately to create acute trauma leading to chronic inflammation within the temporomandibular joint. So, a functional malocclusion can be as little as a millimeter and a half or 2 millimeters of difference between centric occlusion and centric relation that the patient cannot adapt to. Again, adaptation is variable between patients. You know, some patients can adapt to stress. Some patients can adapt to significant differences and changes in their occlusion. I mean, we all see that. We all know that. I mean, I always question how people would come in for extractions and they would literally have 2/3 of their teeth missing already. And I'd say, how are you doing with your chewing? Oh, I'm chewing just fine. Well, those patients are adapting to the loss of 2/3 of their teeth. And so it always amazed me and it applies to all kinds of things about body function and activities, what patients themselves can adapt to, what their bodies can adapt to. And this applies to occlusion just as well. So patients can adapt to big changes in their occlusion. I mean, I've seen multiple people who have, I mean, huge class 2s, huge class 3s, and you ask them how they're getting along with their chewing, or how they're getting along with their speech, or how they're getting along socially. And, you know, the majority, their first response is, well, I'm getting along pretty well. Well, they have adapted that dysfunction, disparity, anatomical problem, they've adapted. And so many people have learned to adapt a functional malocclusion that is relatively small, and other people have not been able to adapt. And when that lack of adaptation overloads these particular two joints, whether unilaterally or bilaterally, then it will cause damage within the joint, leading to chronic inflammation, leading to symptoms of TMD. So I thought I'd address this directly, hopefully simply, to get the point across, that you don't have to look at myofascial pain dysfunction. You don't have to look at muscles to understand it, to understand the whole problem. You just look at the three initial causes. If you're lucky enough that you don't brux, then that will not be a cause. Although then if you brux and then have a motor vehicle accident that jacks your jaw open over the normal extended period, damaging the joint, then you can still end up with TMD symptoms. So those three causes need to be fully and completely understood. And then the fourth, that was again brought to my attention, and I agree, it is a poorly understood entity, which is idiopathic. We don't know what causes it. Juvenile arthritis. Anything I would say about this it would actually be theory. You know, is it possible that idiopathic, the juvenile arthritis, is associated with some problems with the immune system? Yes. It can be associated with some problem that's initiated coming down the birth canal and putting excess loads on the temporomandibular joint. Possibility, it's theory. Could it be that some children, some early adolescents, or actually idiopathic juvenile arthritis is actually documented in very young children, you know, 3 years old, 4 years old, 5 years old, 6 years old. Could it be that, you know, they that early do bruxing, which damages the joint structures, which is not seen in the vast majority of children? They're more adaptable. We all know children are very adaptable, but maybe some children are not adaptable at that early age, which leads to a bruxing, causing idiopathic changes that has not been recognized, possible. So idiopathic is idiopathic, but it is something that if you treat TMD sooner or later, and you treat enough of these patients, some mother is going to be sent to you with her child. If you are the TMD, TMJ expert, with a child who has this problem. Right now, idiopathic juvenile arthritis for the temporomandibular joint is really under the bailiwick under the care and concern of oral and maxillofacial surgeons. And as surgeons, I can tell you, we do not have an answer. We do not have a treatment for that. I think the treatment is understanding the problem, getting actually what is the cause of it, and trying to intercede in the cause, not handling it after it occurs. Just a comment there. So that's what I have to say about the three, and there are only three. If you feel that there's an actual fourth, excluding idiopathic juvenile arthritis, please comment. Please send me a text, an email. I look forward to a discussion with you because I have not seen any others than those three. I'd also like to add here at the end of this, I was going to talk about it at the beginning, but yesterday I had the pleasure of having one of my patients. Today is Tuesday. I always see patients on Monday. I had a pleasure of a patient, an elderly woman who was roughly 68 years old, who had 40 years of headache, earache, jaw pain, neck pain, who went through our service using the device and protocol. And the point being, at the end, we wrapped it up yesterday, and I said, I don't need to see you back. You're doing well. You know how to use the device. You're going to be using it nighttime only for the rest of your life. And as I've happened before, but yesterday was one of those times that makes it worthwhile to do what we do, not just me, but those who follow me and follow us. She said, I can't leave without getting a hug. And as they say in the South, she said, honey, I just need to give you a hug. You just changed my entire life. That is why we should be doing this for patients. That is why I do it. That is why we figured out how a device which unloads the temporomandibular joint, allowing the inflammation to decrease, will decrease all of those symptoms adequately over time so that at the end you get a hug. I'll leave it at that. I'm just going to leave it at that. That's the end. So if you'd like to learn more about the Urbanic device and protocol, get lots more information. The website is www.urbanictmj.com. If you'd like to communicate directly with me, I can be reached at Tony at TMJ Services. Our Director of Marketing and Education, Dr. Naomi Williams, can be reached at Naomi at TMJ Services. If you have any other questions or would like to recommend a theme or topic for me to cover, any topic regarding TMD, I really welcome topics. I would like to cover something that I haven't covered or something that you feel you need more information on. I really encourage you to drop me a line, an email, a text, and let me know what you'd like to hear about, and I will certainly cover it for you. So for today, we'll wrap it up with an invitation to come back next week and to see what topic I choose to talk about next time. Until then, I am Tony Urbanic, and this is TMD Demystified.